Now, PTSD is only one outcome of trauma. So we've really moved a long way over the last 5 years in really putting together the research that has come from clinical research, it's come from epidemiological research, it's come from the VA, it's come from clinical sources, really to be able to understand that a lot of the same difficulties that people who suffer from combat exposure, combat trauma, people who live in very dangerous neighborhoods who are constantly exposed to violence, people who live in homes where there's constant violence in their households, and people who've been the victim of other kinds of physical assault, sexual assault, child victimization, share common difficulties. And that really is what trauma is. It's the commonness. It's not what separates. Because when you address issues of trauma, you really are talking about some common characteristics and common symptoms, and also some common pathways to recovery, regardless of what the source of the trauma is. So that's really that's the perspective that I take. It's not just about veterans. It's not just about victims of child sexual abuse. It's not just about people who've been homeless or have experienced historical trauma. It's bigger than that. And I think there's some common understandings, and there certainly are common evidence-based practices that have been used very successfully and adapted perhaps for particular groups, but not only for that particular group. And that's really where I think we've come today, where we are today. We'll see if the technology is working up here. Now the clicker is not working, okay. So the reason, as Judge Manley said, the reason that we there we go. The reason that we are here today is to find out how to put the puzzle back together. Okay, there is a missing piece, and that missing piece, as we have said, is trauma. And in doing that, one of the goals for treatment courts, or any providers for that matter, who deal with populations that have experienced trauma, is not re-traumatizing people in the process of doing what we do. I'm an optimist. I don't think people intend in the criminal justice system, for example, to re-traumatize people in the course of their practices, but we do. And a lot of times we're just not reflecting a lot on what we might be doing that can be exacerbating the problem. So what we're going to travel along today is to talk about what trauma is, talk about what the effect of trauma is, and ultimately we're going to talk about, and that's in sort of the second half of this morning, how courts can go about changing their practices and policies, and sometimes just habits that we don't even think about, to not re-traumatize and to really start having a trauma-informed courtroom, trauma-informed practices. And it really is, for many, not a dramatic, if you're in a treatment court setting, it's not a dramatic paradigm shift. Okay, it just isn't. You know this. It's a way of thinking about now, okay, how do we put this into practice? What are we doing through our practices and our policies that maybe are re-traumatizing people who come through our treatment courts? So that's really what we're going to do today. We're going to talk about trauma, what it is. Okay. What it is, and of course there's a lot for all of you, not just participants in your courts. There's a lot of benefit to being trauma-informed. For one, it makes you safer. If you understand why someone may be reacting to a laying on of hands, for example, in a way that makes them flinch or make them almost fight back, if you understand that, you may rethink about whether that's the most prudent policy. It's not intentional, but it does make the courtroom safer. It certainly makes jails safer. It makes police work safer, to understand really that responding to someone is different than reacting to someone. Okay, response, of course, involves thought and knowledge, and that's why we talk about trauma-informed responses. I don't think I need to convince anybody here that trauma rates are very high. In fact, what we suggest, rather than trying to remember lots of facts and figures, is assume everyone coming into your courtroom, everyone coming into your program has a trauma history. Just assume that, because they probably do. If someone doesn't, great. Okay, that's great. But chances are everyone coming into your program has a trauma history, some more severe than others, but it's there nonetheless. I just want to give you a couple of types of figures here, just to put it in perspective. These are just for the state of California in 2010. I don't know if you can see these figures. There were almost 4,000 suicides in California in 2010. Now, suicide has rippling effects. Family, providers, neighbors. There were almost 500 drownings in California in 2010. Now these are, I just sort of pick out different kinds of events that we maybe don't typically think of in criminal justice as an event that would have an effect. Transportation fatalities. It doesn't surprise you that there were almost 3,200 fatal car accidents in California in 2010. Maybe you thought it was higher than that. And there were 4,500 poisoning deaths. So we could go on and talk about this. And I always put like under 18 just to see, because we often think of the accidental death of a child is even more traumatic in many respects than of people who are adults. Lots of fires, and all of these trauma events, these traumatic events, are more likely to occur multiply to people. Okay, maybe we all in here are lucky that we haven't had these kind of experiences recently, especially. But if someone has a residential fire, they're also more likely to lose a family member to homicide. So it's not singularly, and it's a very complicated issue why that is. Poverty has a lot to do with it, and poverty neighborhoods have a lot to do with it. So that's just to give you a picture of California. I'm just going to give you a perspective here. One of the jail diversion studies that we did at PRA at the Gain Center looked at people who were being diverted out of jail who had a mental illness and or a substance abuse disorder. And they were asked in their lifetime, had they ever been beaten, assaulted, raped? These are serious traumatic, violent events. And as you can see across their lifetime, almost all the women had been. And this actually surprised us, and maybe shame on us, almost all the men had experienced that as well. So it's, as I said, it's universal. And then we asked them in the last 12 months, had any of these same things happened to them? And as you can see, for the men, it's even higher. So it's an ongoing problem. It's not just happened in childhood or just happened before they left their particularly assaultive relationship. It's ongoing. And that's, I think, really important to know that that's the place where many people are coming from who go into treatment courts, treatment programs, diversion programs. I made reference to the study that we did that Judge Manley's court, both San Francisco and Judge Manley's mental health court were in a study that we did on mental health courts. And we asked them specifically, and again, just to give you a perspective, 70% of the women in our study were sexually assaulted before the age of 20. But also 25% of the men were. And we know that this is a very underreported event. Okay, so again, 3/4 of the women who are coming into treatment courts have been sexually assaulted before the age of 20. And then the family disruption. Half of the women lived in houses where parents threw things at one another. And some of you might know that these questions sort of track the ACE, the Adverse Childhood Events scale that's done, and actually was done in California with Kaiser Permanente and with the CDC in Atlanta. We pulled out just San Francisco and Santa Clara, and you can see here that 70% of the women in our mental health court study and 75% of the men experienced child physical abuse. Okay, these are adults, obviously, they're in the adult mental health court. Again, this is hard to talk about, by the way. This is not an easy topic. And we will get to some videos and some pictures that frankly are a little disturbing, a lot disturbing. And I just want to prepare you for that because it is a very hard topic. And I will confess, once, not this summer, the summer before, I did about 10 of these, but they were twice as long each time. I was shot by the end of the summer. I did not want to go out and talk about trauma anymore. And as I put the California statistics up here, we would do that for each community. I went to Tucson the day after Jared Loughner pleaded guilty and was sentenced to life in prison, and the Tucson Police Department was at our training. So it's a hard topic. It's very raw and very real for people. And the other part of that, it's not just people who come into our programs who have had traumatic experiences. It's people we work with too. And putting vicarious trauma aside for a minute, I mean, just in our everyday lives, okay, just in our everyday lives, the people we work with experience trauma as well. So that's really important to keep in mind, not just of the participants, but also of the people who we work with and the people who we come into contact with, maybe indirectly work with. As I mentioned, the Adverse Childhood Experiences Study, and I want to draw your attention to something. This document was out there. I don't know if it was put in your materials or not. It's called Trauma-Informed Drug Courts, and something we put together for this event. And on the very front page, it lists a lot of behaviors that are directly correlated with childhood experiences, such as, well, a disruptive household and child abuse, neglect, and assault. So just all of these, for example, illegal drug use, which I know is pertinent to everybody, no matter what kind of treatment court you have. Illegal drug use is 7 to 10 times higher for people who experience childhood abuse. 7 to 10 times higher. Now, for each one of those ACE, household instability and abuse, if you go up incrementally, the rate gets higher. So if you have clients who have experienced any number of these ACE items, with each one you add on, it increases their risk. It's not just one and there's a flat rate. And for every single behavior that they've looked at, we might call maladaptive behaviors, in some cases very dangerous, sometimes illegal. With each increase experience as a child, it increases their risk of illegal drug use, cigarette smoking, which although it's legal, it brings other problems with it, other health-related problems. And one of the other pieces of this is it has so much effect on health. And while that may seem like an odd topic, talking about treatment courts, when you have people who have chronic pain, they want to relieve the pain. Drugs do that very effectively. That's why they manufacture them, and that's why we take them. So it's the physical disability and pain and chronic pain brought about by experiences around trauma directly feed into drug abuse and addiction directly. So it's keeping this all in place. As I said, there's a lot of unpleasantness and difficulty here. If you have a drug, I know all of you this is the drug court professionals. Some of you may have a co-occurring court, some of you may have an adjacent mental health court. But the reason I put this slide up here is if you have a drug court, you have a mental health co-occurring court. Because there are only 400 mental health courts in the country, and we just counted them recently. We just counted them. And there are pushing 3,000 drug courts. So even if you believe that you are a drug court, well, you have a lot of co-occurring people in there as well. So the information, while we may talk about mental health or we may talk about co-occurring, it's in your court. Okay, it's in your court. Even if you have a parallel mental health court, you have people with co-occurring disorders in your court, which this you may have picked up if any of you were at the NADCP conference in July in DC. This document just came out. It's called 6 Steps to Improve Your Drug Court Outcomes for People with Co-occurring Disorders. This is it's a good piece of work. And so if you're just new to that, or maybe your mental health court disbanded, there have been mental health courts that have gone away because there really isn't much funding for mental health courts compared to drug courts. It's a worthy document looking at because it really talks about a lot of what is frustrating as a drug court administrator, drug court coordinator, is people relapse a lot. That's probably one of your biggest frustrations is the relapse. Co-occurring disorders are so prevalent among people who relapse. Okay, so hitting the mental health piece and the drug, the substance use piece is really important. And that document that came out from NADCP is worth taking home. If there are some out there, any of the materials that are out there, if you want more of them, just let me know. We can get them to you. We can ship them to you. So we have a lot of drug courts and not a lot of mental health courts in the United States. In fact, there are 8 states that have no mental health courts. Now, what do you think New Jersey is one of them. That surprised me when I found that out. What do you think the chances are their drug courts have people with mental health problems? Absolutely. So this quote from Faulkner we just include because it really highlights the essence of trauma. Okay, it really highlights the essence of trauma. It doesn't go away. Okay, it doesn't go away. California has a probably the most interesting range and heterogeneity population in the United States. If there is an ethnic group, you have it. If there's a special interest group, you have it. And you have a lot of advocates, very politically active people. That's really key to knowing how to improve the outcomes of your treatment court, is really knowing who your population is. California has, I think, the highest number of veterans, for example, in the United States live in California. And you also have the most veterans treatment courts in the country as well. You have, just an extraordinary high number of living veterans today from all the conflicts, not so much World War II anymore, but certainly from the Korean War forward. And that is, whether you have a veterans treatment court or not, you're going to have veterans coming into your court. And they pose some interesting challenges. challenges, but also they have some strengths to draw on that people in other treatment courts may not have. Judge Manley talked about the Vietnam veterans and the chronic homelessness. Well, certainly among the more recent veterans, they have more social assets than many other people who come into your treatment program. They're more likely to still be attached to family. They're more likely to have more education, more training, more job skills than maybe people like them in the civilian community. Those are assets you can build on. They haven't burned every bridge yet. Okay, they have not burned every bridge, and many people who come into your court, for example, who've been in and out of jail and have been homeless and have a whole set of difficulties, have probably burned through pretty much all of the social supports they've had. That's not true with today's veterans. When I mean today's veterans, the younger veterans, they still have social assets, and those are something you can really build on with regard to their outcomes. A number of other populations that are really important to be aware of. I don't think I have an accent. Maybe I do. I don't have a New York accent, I know that. I'm not from New York originally. I live in New York now. I'm from Ohio. And where I grew up in Ohio, it was a pretty homogeneous population. Just because we elect the president every 4 years doesn't mean that we're a perfect match for the rest of the country. And when I moved to New York, I still remember vividly, I was a swimmer, and I joined a community center so that I could still continue to swim. And I remember in the ladies' locker room seeing a woman with a tattoo on her arm with a number. Now in Ohio, I never met someone who had survived the Holocaust. I read about it. You knew it. But until I saw her and saw that on her arm, it didn't hit me. That is historical trauma. And what they experienced, they've passed on to their children and their grandchildren, inadvertently or not. And that's true with Native Americans. It's true with immigrants. It's true with a large number of people. There is a historical trauma there that is hard for us to step inside of. And this is true, as I said, with Native Americans and many populations who you have in California have experienced intergenerational trauma. And that can be part of the missing piece. It can be part of what's keeping them from moving on. We have one of the, in any given week, there are over 500,000 young people under the age of 25 singularly living alone on the streets. Okay, there's over 500,000 kids under the age of, I still think 25-year-olds are kids, but under the age of 25. About 300,000 of those are under the age of 18, living on the street. Now, what drove them there is often trauma they've experienced at home. And of those kids, 20% of them are LGBTQ kids, which is twice the rate of that in the population. So kids who are lesbian, who are gay, who are transsexual, are more than twice as likely to experience homelessness as a kid than their proportion in the population. So this is a group of individuals who get kicked out of their house or driven out of their house, perhaps because of that fact about them. So again, and California probably has a larger proportion. You have a lot of young people. So these are groups of people who you need to work with and work to understand. They're not just your average person coming in, well, they perhaps are your average person coming into your treatment court. So understanding the uniqueness of that trauma is essential to creating programs and creating strategies to overcoming that. Or you'll see the relapse over and over and over and over again. Pain drives people to use drugs. I don't think anybody wakes up in the morning and says, I think I'll be a drug addict. That's not usually the process. So it's really important to understand the population. And California, I don't need to tell you this, I know all about Senate Bill 109. California has experienced an enormous influx of people out of prison. Parolees, and this is reported by California Department of Corrections, between 1/3 and 1/2 of parolees are homeless at any point in time. So you have not only coming out of prison, and is there anyone in here who doesn't think state incarceration is traumatic? Okay, so they're coming out of state prison and they're homeless and probably have very few social supports. So that in itself, if you think about a third to a half of parolees are homeless at any point in time. That's a bit, and California is experiencing the largest growth in that population in your communities. They're going to show up in your treatment courts. My guess is they already have. So that's a very, very, it's not unique to California, but you do have a bigger issue with that than most of the other states do. So just a quick summary, this is not changing anybody's, as I said, this is not a paradigm shift for people who devoted their lives to working in treatment courts. You're already there. And part of this is to help you know how to do that better, is to know that part of what's missing, part of what may be missing from policies and procedures are knowing what trauma is, knowing what the signs and symptoms are, knowing who your population is, how it might be unique with them, and learning how to respond. Again, not reacting to that, not reacting to it, but how to respond, and as, you know, it makes everybody's life better. Recovery is a word that, I'm going to tell a story about Judge Manley here. Years ago when I was observing his mental health court, there was a man in the mental health court who had relapsed and started using drugs again. And the district attorney said at the time, and I don't even remember what his name is, but it was the prosecutor, asked what the crime was that he had committed that had brought him back, and he said it was Judge Manley said it was a drug offense. He was arrested for possession, and the prosecutor said, oh, relapse is part of recovery. And I thought that was really interesting. I mean, but so that was the attitude. This is going to happen. Okay? It wasn't an assault. It wasn't a home invasion. It wasn't intimate partner violence. It was another drug offense. But that's part of, and sometimes that word is unpopular, but I think that's important to keep in mind that people cannot recover until whatever is broken in them is given a chance to be fixed. Okay, they cannot recover. And they're not going to stay on the course of treatment and without having their trauma addressed. One of the things I want to make sure that I'm not a clinician, okay? I'm not a clinician. We're not going to talk today about how to deliver trauma services. There are people who do that excellently, and some of you may be in the room. We're going to talk about what evidence-based practices there are, but we're not going to talk about how you do those. Those require special training, hours and days of special training. So we're going to talk about those so you know what might be available in your community or advocate for certain types of services, but not talk about how to go about, directly providing direct services to people. I don't want anybody to be disappointed that isn't going to be part of what we're talking about today. How are we doing? I'm going to let you hear. SAMHSA is the Substance Abuse Mental Health Services Administration, SAMHSA, funds a lot of work around trauma. They fund a lot of trauma services through grants, through direct services. CSAT is part of SAMHSA. Some of you may have CSAT grants. CMHS is part of SAMHSA. And trauma is really a big push of theirs right now in terms of including, we do a lot of training with drug courts through CSAT. The easiest, they've tried to distill down what they want the definition, a universal definition of trauma to be, so that we can all be talking about the same thing. And the easiest way to remember it is we talk about it being the 3 E's. It's an event or events, and it's how the person experiences that event and the effect it has on them. Now, the whole definition is actually in this, okay? It's the very, very top thing is what is trauma. But it's the easiest way to think about it. It's not just an event, because every one of us has experienced a traumatic event and it didn't seem to have long-term problems for us. And sometimes it puzzles us as why it bothers someone else so much and it didn't bother us that much. That's because we all experience it differently. And it has that long-lasting effect. That's really what makes something a traumatic event versus, say, a crisis. crises and traumatic events are not the same thing necessarily. What are some examples of traumatic events that come to mind when you think about trauma? I will call on people. No, you said. Give me an example of a traumatic event. Yes?
Working in family court, we have parents that come in and they have their children removed from them. I can't imagine anything more traumatic than that.
Having children removed from the house. Yeah. Anybody else? She broke the ice. Come on. Yes?
Physical, like floods, tornadoes.
And you have a lot of those weather-related catastrophes in California too, don't you? Mudslides, fires, earthquakes. Yeah. And, okay, go ahead. Back. Yeah. A death in the family. And families that are involved in courts have a lot of deaths in their family. Okay? Yes, sir?
Combating war, being a civilian in war.
Absolutely. And this is something we've come to understand too with how we define combat. It's affecting women soldiers more than in the past. Certainly the nurses during the Vietnam War, they weren't in combat, but they were certainly helping people with combat. They were handling bodies, they were patching people back together. And this has a similar kind of effect on people. Any other examples? We've got, disasters, combat. What else? What did the ACE look at? Childhood trauma. And even living in a household where your parents fight increases your risk of engaging in maladaptive behaviors like smoking and using drugs and drinking, etc. Yes?
Did it also look at living in a household with a parent, a parent that is incarcerated?
Yeah. Hi, Kathleen. I just realized she was sitting back there. Living in a household with parents who are a parent who is incarcerated. Recently, I've been working on a study on juvenile mental health courts, and in our two different courts, half of the kids in our study, half of them, these are kids in treatment courts, had a family member go to prison. Half of them. A quarter of them had lived in a household where someone had attempted suicide. So, I mean, these are the children's lives. Okay, this is the household that they're living in. What else? Emotional abuse. A lot of kids report they never were sure they had enough food, or they didn't go to school. There was no one to take them to school. Okay, so these are all types of traumatic events, and I think we hit on most of these. Communities can experience trauma as well. I mean, probably the most obvious is 9/11, and the community was defined very big on that one. But you had the Oklahoma City bombings, you had the Sandy Hook shootings at the school. I mean, unfortunately, we can list them, a lot of them, where it's not just the people who were there who directly experienced it, but the rippling effect can be quite profound. And that's something too, when you're working, if something has happened in your community that would affect your community, the people you're working with, that is something to really pay attention to. Okay, really pay attention to. Maybe someone that's a leader in the community, a pastor or someone has died or been killed. I mean, that can affect people more than just their direct family members. We're going to watch a video. This is, I'm pretty sure this will work. Officer Tully is a police officer who was shot on the job. And she talks about her experiences with that, the effect that it had on her. Now, it is a singular event. Some people have lifetime of trauma, but she describes really articulately what trauma is and what it does. So we're going to listen to Officer Tully, and then we'll come back and talk a little bit more about.
And then around 10:33 in the morning, a call got dispatched for my sector for a man beating a woman. And I was close to that sector. I was close to where the location of the call was. So I wound up responding to the call, and I had 2 units backing me up at that time. When I got to the gas station where the incident was allegedly taking place, I exited my car, and I looked around, and there was nobody there except for two women sitting in a car. And I went to go talk to the women, seeing if they had seen the alleged attack that had taken place. At that moment, a man came around the corner of the mini market and said to me, as he started to approach, I said to him, "I'll be with you in a minute, wait by this car that was there, a yellow Jeep." To which he cupped his hand to his ear and he said, "You want me to do what?" I figured he couldn't hear me, so I repeated myself, and he then started to approach again, saying, "You want me to wait where?" And by that point, he had just closed the space between me and him. He wound up at that point punching me in the face and leg sweeping me. As that happened, the radio that was in the holder on my gun belt wound up getting dislodged. He started beating me, hitting my head up and down on the pavement, and he started talking about how women shouldn't be police officers and how he had to kill me. He was militarily trained. At that point, I remember that he was pulling on my gun, and as he did that, the gun came onto my stomach. It was still, my keepers gave on my gun belt, and now the gun was sitting in the holster on my stomach. And as I tried to hold it in the holster, I remember thinking, if you let this gun come out, you're dead. So then I heard the most sickening sound.
the dog's named Avery. You can follow Avery on Facebook. Avery goes into court with the kids up on the witness stand, and he'll sit there with them. It's the calmest lab I've ever seen in my life. I know they're lab Goldens make, but this dog is very calm. And so we'll sit up on the witness stand with the child who's facing his or her abuser right in front of them, and during trial, I mean, you all know how this goes. And the kids are like, no, I'll be okay because Avery will be there with me. So there's this dog that's specifically trained to help kids, and you can see how it would help adults as well, but they've got specifically for the prosecutor's office for all of their child victims. And so they found one way to sort of begin to address this issue of the trauma in children. And a lot of times, families don't want their children, obviously, to go in court. But this is a way that the prosecutor has gotten this canine companion to help with that process. Yes, sir.
Yeah, two things that I found interesting about Officer Tooley was that the incident had no expiration date. Her inability to keep track of the actual time, day, year. And then the other thing, the comparison between crisis and trauma. I've never heard it put across that way, and that's a really, I think, important piece.
Yeah, thank you for that. It is. And again, she's someone who has many resiliencies. And as you say, I think that's an excellent way of putting it. There was no expiration date on that. She is still a police officer. But she said she thinks about it every day, but in a different way. Yes.
There is a whole equation about trauma. There's a book that's called Too Scared to Cry, and it's a very, very great book that's from a famous San Francisco psychiatrist, and it tells the difference between a single episode of trauma and ongoing abusive trauma, and how it affects children specifically, and how it may play out and be treatable in adults. And so a more complex, it's a very complex equation about trauma that I don't want to trail off in different directions. The officer's situation was an episode of trauma that is beyond any comprehension of most people in life. The majority of people in life just don't experience that grave of trauma. That's quite, who could imagine?
Right.
So just to kind of touch, there's a whole equation about the long-term versus the individual trauma. Not saying that one is more traumatizing than the other. Certainly, hers is remarkable. PTSD is that is the how to describe it is that the experience of something beyond most humans' comprehension.
And most people who have experienced a traumatic event don't develop PTSD. And we do know that people who have other risk factors, well, I'll jump ahead here. I can't remember if I can go back or not. I don't think I can go back, so I'm not going to go back yet. But in your practice, in your courts, you see people who come in. I talked about social assets. Building on what those social assets are. Sometimes it's resources. Literally resources to get treatment, or even in your community, you may not have the resources available for people for the kind of trauma-specific services that they need. And we'll talk a little bit more about that in a little bit later. But some of these resiliencies are you can work on as a program. For example, people who can go to work. Work is important. And a couple of times I've talked before groups, and there have been people from NAMI there. And families are not always a good influence on people. But a lot of times people who come into treatment courts have really burned their bridges with their family in a lot of really profound ways. And same thing with friends. And oftentimes people who are in treatment programs such as drug courts and mental health courts, the only friends they have are people like them. And I think often, again, one of those programmatic issues, often we don't let people associate with people like them. And it's all they have. And we know that social supports are really important, so it's not just taking away those supports as much as we don't like them, but it has to be replaced with something. Because the ones that we traditionally think of, and reuniting families I know is often a goal, and reuniting parents with their children and rebuilding those relationships. But for people who've been around two tours of duty through the court, they don't have a lot of social support left. And so it's interesting. The NAMI families often will say, well, that's the only friend my son has. So now you're telling him he can't have his one friend. And so I think it's something to keep in mind. And I also think this is why it's really important to involve peers in programs. Because these are people who in many cases have graduated from the very same programs that you're working with or a similar program. They've been through it. They can talk about the challenges. They can become not just, it might even be a certified peer mentor or a peer specialist, and that's great, or a recovery coach is another phrase that's used. But that is really important for long-term success for people in treatment programs like this. When there's a lot of conditions and a lot of restrictions, someone other than us has to tell them why they should be doing this. Okay, and peers are a very good way of bringing the real-life experience of success back to the people who are struggling with early phases of the program. And we have a lot of information about that too if you want to. We can talk about that later. Certain people have certain risk factors that are innate. We know, for example, people who have lower intelligence, no matter how you measure it, are at greater risk for traumatic experiences. And we know that people who experience injury, or maybe it's because of their drug use, but injury and have traumatic brain injury are at greater risk of suffering subsequent traumas as well. And the lives that many people come into drug courts and mental health courts and co-occurring courts and veterans courts, the life they lead often puts them in a less safe environment that, again, increases the risk. We know that people who have experienced one trauma, and it speaks a little bit to what the woman in the front here had said, one trauma, they're more likely to experience subsequent traumas. People who go into the military, women in particular, have very high rates of pre-combat trauma, much higher than their civilian peers. Many women say they go into the military to get away from a really bad situation. So if a woman has experienced combat trauma, chances are she experienced pretty significant trauma before she even went into the military. And then there are subsequent things that happen. Women veterans, for example, are 5 times more likely to be homeless than male veterans are. And as of a couple of years ago, and I mean like 2, there were only 2 homeless shelters for women veterans in the United States that accepted children. 2. So, losing children, I mentioned having your children taken away from you. So these are, if a woman has experienced combat trauma, assume she had a lot of other stuff going on both before and after. And we know military sexual trauma is extremely pervasive as well. When people are exposed to high levels of stress on a regular basis, they create way too much cortisol in their brain. And it keeps them, she talked about that hypervigilance and that being on edge all the time. Your body loses the capacity of responding normally to situations. You're on high alert all the time. We've all had that feeling. When you get scared, you got that adrenaline feeling. People who experience multiple traumas have that all the time. They're on that level of high alert. Your body just gets worn out. You can't function at that level. You can't. But that fight or flight response, you're constantly in the fight response. Think about how this plays out then in behavior. Okay? Someone touches you in a non-aggressive way. Okay? It may be an appropriate touch. It may be not an appropriate touch. But just the responses, and we can imagine how that escalates from there. And numerous traumas certainly have that kind of impact on people over and over again. And we're just learning more about this. I think it's really fascinating. It erodes the brain, it erodes the normal neurons and pathways in your brain. Drug abuse does too, by the way. And it almost rewires your brain.
There's a very interesting article about cortisol levels, and we have a program here in San Francisco, that a companion dog, depending on the situation, but a companion dog really does lower the cortisol levels. And so we have a program here where homeless people on the streets, veterans or whatnot, can also get a dog from the shelter, and they're responsible for that dog, and they go to a station and get free food. But it's just to mention, because that is a new thing that we're studying, the cortisol levels in the brain.
And it increases even just for people who have dogs, at home, and you wouldn't be considered a trauma survivor. Petting your dog actually raises your oxytocin levels in your brain, which is a calming hormone, and it also increases it in the dog, which is pretty cool. So it does you both good. And we know pet therapy programs in prisons and others have been generally successful in terms, and teaches responsibility and caring for another living thing. So one of the things that's really important to avoid and is blaming someone for their inability to really cope with the trauma. Just because their brothers seem to do just fine, it's not their fault that they're not doing fine. People are very different. I mean, if you have any siblings, you know. If you have children, you know. It's just people are different. People come in with different experiences. Their interpretation is different. How they experience, say, failing a grade or being held back is different. So it's really, although we talk about individualized experiences, it is very personal, but it's also not an avenue to blame or to sort of hang responsibility on. It's a way of addressing, especially when you know there are certain things you can't change, like who your parents are, but you can change employment opportunities, you can change connections to the community, you can bring peer groups into the court to provide peer mentors and friendships with people who are healthy friendships, etc. So it's a way of thinking about what someone's risks and resiliences are and really build on their assets. So just to bring it full circle is that it is that those 3 E's, just keeping that in mind, not cutting it off at the event, but it's all 3. It's the event, it's the experience, and it's the effect that it has. Like Officer Tully said, it was pervasive. She couldn't run. Okay, everybody seemed like they were out to get her. And thinking about how your programs and your own behaviors might be exacerbating the effect well beyond the timing or the expiration date, if you will, of the traumatic event. I think. Or where's the timekeeper? Is it break time? Okay. So we'll take a break.
So thank you. We're going to have a 15-minute break. And so please, there are refreshments and an opportunity for everyone to talk out in the front part of the building. One thing we do ask, please be in respecting the rules of the AFC, please don't bring food into here or
Like
drinks.
water in.
It's very important because that is an ironclad rule they have here. It's the only way we're allowed to use it. Oh, I'm sorry. All right. We will have a 15-minute break, and please don't bring food or drinks into the auditorium. This is not owned by the AOC, and therefore we have to keep it in pristine condition. Thank you. Wonderful job.
Thank you.
Thanks so much.
Thank you.
Are we on time?
Hope you didn't
Get started again right away, and so welcome back, and we'll start up right away. I do have a couple of announcements. First, at approximately 11:45, we will break for lunch until 12:30. It will be in the auditorium, and we are very grateful to the Administrative Office of the Courts for providing the lunch, and so please take advantage of it and the opportunity, of course, to talk to one another. Also, I wanted to take the opportunity, and I hope she's still here, to introduce Nancy Taylor, who there she is. Nancy, please give her a hand. Nancy is a driving force behind the efforts we make in collaborative courts, and she has been so helpful to all of us over so many, many years, and we're very grateful to her. With that being said, I'm going to turn it right over to our guest speaker. Thank you.
Okay, thank you. Is this microphone working? Well, okay. I'll try not to yell into it. For this last hour and a half approximately, what I want to talk about are trauma's effects, and then talk about how do you go about becoming a trauma-informed program or trauma-informed court, and give you some food for thought, okay, ways to consider how you can move to becoming trauma-informed and change the way of interacting and improve the outcomes for your clients. This is just a summary slide since we're after the break, just remembering what trauma is, okay, and that it's the 3 E's, the event, experience, effect, that it can be ongoing over a lifetime, as we've talked about, or it can be a single event, like Officer Tully experienced. People experience it as more than just momentarily disruptive. It's terrifying. Okay, it's overwhelming. It overloads your senses. It prevents you from responding in a way that might be a normal response. Okay, you're on this heightened alert. It makes you hypervigilant, and it changes the way you think about not just the world but about yourself as well. Because sometimes we blame ourselves for things that happen to us. Why did I go there and that happened? Why did I go back? I mean, and that really is part of the process as well. It diminishes self-esteem. It diminishes, consequently, people's ability to really move on. And as we know, based upon the resilience factors and risk factors, the response to trauma is very individualized. And it's hard to imagine in some of the court programs the sizes of the people who you have under supervision that you can individualize and really know everybody's story that well. But it should be at least a goal to try to get to know everybody's story, whether it be through their caseworker or whether it be through the judge, case manager, program coordinator, but it's really important because it is very individualized. There's no cookie-cutter response. You just can't have a list and check off the boxes. And not everybody gets better. Okay, some people get stuck. So trauma's effects are very pervasive. As Officer Tully talked about it, not just health, but in her ability to work, and her ability to really move on and get on with her life, both personally and professionally. And people experience this throughout their lifetime. And as I said, it has a pervasive effect. This isn't letting me, there we go. The next video, and this is the last video we're going to watch, are 3 people who are survivors of traumatic lifetimes. They were all in counseling, in therapy when they made this video. So they had support and had the responses that were necessary for them. But they talk about not only what happened to them, but what I think is one of the reasons I selected this series of people for today is they really link it to their substance abuse and why it is that they began using drugs and continued to use drugs, and they link it back to their traumatic events. So I thought it would be especially good for today.
I was the sergeant of the guard, and I told them at the time, if it comes from the dark, shoot it. I didn't care if it was a baby, woman, child, snake, dog, whatever. Shoot it. He yelled, Sergeant of the Guard. Before I can say no, he picked up the baby, and his head went kaboom, went off. All I could see is the body going down like that. Okay, I told the psychiatrist, I told my sergeant, I told my lieutenant, I told my captain. I said, I can't get over this. He says, well, you're on your way home, don't worry about it. You don't have to go to fight no more, so you're on your way home. That's fine and dandy. I get home, I go to sleep. All I see was this kid, the body going down like this, wiggling down. Okay, I take a job, I get a job, I work, come home, I'm scared to go to sleep. But I do. And I wake up with the screaming Mimis. I scream, no, no, no. That's all I can say. But I'm taking my medication fast as I can get it in me because it's working double dose. And the shakes, the screaming stops for a while, but now my body gets immune to it. And that's when it causes a problem. So now I'm addicted to drugs, medications, prescription, okay?
Sometimes late at night I sleep in the park and I wind up getting raped, or I sleep in abandoned buildings and somebody come in and rape me there. I sleep in cars or under the tunnel in cardboard boxes, and somebody will come and rape me there, 2 guys or 3 guys, it don't matter how many, they'll, just hold me down and rape me. There's nothing I can do, I'm tired anyway, so I just deal with the pain. I felt like I needed more drugs to hide the pain and the feeling of what I was going through of being raped, because it kept me in a deep depression, and I didn't want to feel it. So I used a lot of drugs. I used a lot of myself to prostitute again, to get the drugs to help me stop feeling.
My abusive relationship started after I graduated from college. Okay, I fell in love with a guy. I was with him for like 13 years. In the beginning, everything was fine, but later on, it became very, very abusive. We fought. But then I had to realize, too, was that he was an alcoholic, and I became an alcoholic along with him. My abuse on the street was by guys that I dealt with, like getting beat up for dumb reasons, by the crack dealers that I used to sell for. I mean, the physical abuse I took from them guys was ridiculous. I mean, I was almost thrown off a rooftop. I had a Uzi. I had a Uzi placed in my vagina and clipped. Just because of the fact that I was short with a pad, okay?
Okay. I think all 3 of those, Robert and Vicki and Wanda, all talk about why they, at least not necessarily why they started using drugs, but why they continued to use drugs throughout their, they talk about the pain. the pain of their victimization, the pain of their living on the streets. And one of the messages that I think that we can get from those videos, and I know they're hard, and I probably should have warned again, they're very hard, but those are very real stories. These are how many people experience life on the streets, and how their drug. I guess I'm not surprised that their behavior, as maladaptive as it is a means of survival. Okay, it's a means of survival, and I think that's something. If we think about changing the way we think about what they're doing as not bad behavior, but it's allowing them to keep putting a foot forward in front of the other, and especially people who have such severe trauma histories, that people are going to figure out a way to get through to the next day. And for people with very severe trauma histories, it's often through using substances. People who have trauma, this is the place they're coming from inside themselves. Okay, it's a place of fear. Vicki talked about being homeless and living out in boxes and living under the bridge and being raped sometimes by multiple people in one night. The powerlessness, and Wanda especially talked about that with her crack dealers, and anger and pain. And there are differences, although probably not as profound as maybe we thought 20 years ago. Men and women often express that differently. Okay, the fear in that, and the aggression is, men are much more likely to talk about the sorts of the code of the street. You know, not being a victim, not being weak, not being seen as weak, and sort of becoming the aggressor. But frankly, they're coming from the same place here. But the way in which they express that is different. This isn't to say women don't also act aggressively, but for the most part, that men and women it will look a little bit different, and a lot of self-destructive behaviors in women who have trauma histories, a lot of self-destructive behaviors. So any kind of trauma, whether it be childhood trauma or a trauma experienced in adulthood, does have a long-term effect. Okay, it affects many, as we say, the pervasive effect, it can lead to substance abuse, it can lead to behavior problems. Often the combination of those two are why you know the clients you know. They've been using, and the behaviors have gotten them arrested and brought to your court. People who have trauma histories often have a very difficult time sustaining relationships. And again, that's important for social support, is being able to have a relationship, not necessarily an intimate relationship, but even friendships. And of course, it affects mental health as well. Vicki talked about the depression. And she talked about, just continuing to take drugs because of the depression she was experiencing. Robert talked about the psychiatric drugs that he was taking to try to deal with the trauma he had experienced in Vietnam, witnessing this baby being killed, not being able to sleep, and so he started taking his medication because it worked so well. And then he became addicted to it. I mentioned earlier that people who have, especially childhood trauma histories, have just an escalated risk of becoming using illegal substances. 7 to 10 times greater likelihood of using illegal substances because drugs work. I mean, it's the reality of it. It's, as I said earlier, it's why we make them, but it's also why we take them, because the drugs do hold the pain down. In fact, many people who go into trauma-specific services and they become clean for the first time, what happens? Or if they're in your drug court and they become clean for the first time in years, what happens? Did you say it's too much? It's too much. Everything starts coming up, and what is the way to keep it from coming up? Drugs. Push it right back down again. So in understanding this dynamic, first of all, they're at greater risk for using illegal substances, but the relapse process is quite common. And and that's why it's really important to have people who know what they're doing, providing these kind of services. And the expectation is, to quote Judge Manley's prosecutor, relapse is part of recovery. And when you add trauma onto the piece with substance use, there's much recovery to happen. I mean, people pick substances, the type of substances they abuse, based upon what they want the effect to be. Some people just want to numb the pain. Okay, they just want the pain to go away. Others want to feel very powerful, and they're going to use amphetamines, or they're going to use crack cocaine. It gives them a false sense of power. And so the kind of drug that people use is addressing the issues that they have. Okay, what they are. It isn't just a random choice of drugs, although it may appear that people will take anything. But there is a drug choice, and because they're successful. Okay, they are successful. It's not coincidental that I read very recently that the successful, although it may not seem that way, the successful attempts at restricting, say, the OxyContin drugs, because there's been such a concern about it. You can't get a refill. They can't be ingested in the same ways that they could a few years ago. What impact has that had on the drug of choice in a lot of communities now, as OxyContin has become less available? Heroin. Okay? Okay, they're not going to crack cocaine from that. They're going to something else that's very sedating. So it's the kinds, as we put pressure on part of the criminal justice system, let's say law enforcement and in the pharmaceutical industry, it's not going to keep people from using drugs. They'll shift to something else. Okay, and I think that's important to keep in mind.